I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Hello, and welcome to this episode of IDD Health Matters. Our guest today is Dr. Lauren Clark. Welcome, Lauren.
Thank you, Craig.
So, Lauren, how did you get into the work that you do? First of all, tell us, what are you doing in this field right now?
You know, that's a really good question. Right now, I'm at UCLA. I'm the Shapiro Family Endowed Chair in Developmental Disability Studies, and my appointment is primarily in the School of Nursing. So I'm a nurse, a public health nurse by clinical background and training. My PhD is in research, and at the University of Arizona, that was clinical nursing research. And I had a background in medical anthropology. So I kind of came at this through that route. I went really quickly through my bachelor's, master's, and PhD in nursing. And I worked, because I was at the University of Arizona, along the U.S.-Mexico border with low-income Mexican-American women and children, and saw myself as having a lifelong career at that time in immigrant health and health disparities. And I loved the work that I did. Well, life happens. And
It does, doesn't it?
And so I am no longer in immigration and health. And in fact, I thought that might be worth sharing how that came about, that
Please
change.
do.
So I was the recipient of 2 very competitive NIH grants, and I was doing research and doing qualitative research, listening to immigrant mothers talk about child health and healthcare and what they did at home and how they interacted with healthcare professionals and their disappointments and their challenges and how they learned resilience and how they advocated for their children. And I very much enjoyed that work. But the funding pipeline changed significantly after 9/11, and the funding for immigrant health was no longer really available. So I also realized that I had been living my own maternal journey, if you will, of learning how to do those same very things, learn and understand my 2 children with developmental disabilities, learn how to advocate for them in the healthcare system. Even though I was a nurse, it was not exactly evident how to get the best care or the best educational opportunities.
You know, I think about that sometimes. Even as healthcare providers, it can be challenging to navigate the system that we are trained in and that we know. Can you imagine the challenges, of people, whether you have a disability or not, sometimes in navigating the healthcare system? And then you add the challenges that we all know about in healthcare for people with disabilities, and you can see why it can be pretty tough sometimes for people to get good healthcare.
Absolutely.
Yeah.
And then add on, furthermore, concerns about your immigration status or English as a second language. And that word intersectional carries a pretty powerful punch when it's really so much more challenging for many people.
Yeah. So that led you were parenting.
Yeah, I was parenting and I was doing my research. And then the research kind of dried up. And meanwhile, I was getting over what in hindsight was a period of time of some distress on my part, really dealing with my own ableism. So I had 2 children, one with an intellectual disability, one with a developmental disability. And I was so well educated in the medical model, and I understood that we were there to help or we were there to fix. We were not necessarily there to serve people where they were at. And
just for clarification, to make sure everybody knows what we're talking about, when we talk about the medical model, it's kind of an outdated way of seeing disabilities as they have a disability, that's a medical problem that needs to be fixed, right?
Correct. And that a disabled life is inferior or perhaps not worth living, and that the only way to kind of help or fix, help coming from a sort of a top-down model, that I have knowledge, know-how, I have stuff that I can sort of, through a charity act, give to you and help you. Or fix, I can help fix you so you are no longer in that sort of bad place of being a disabled person. And those were sort of the sentiments, I think, that were all rolled up in the medical model.
Yeah, I agree, and I think that's the way that many people were taught about how to approach people with disabilities. People were told, oh, your child has a disability, they need to be put away from society and basically hidden. And we've certainly moved away from that over the years.
We have. We're in a
Yeah.
much, much better place.
Yes.
But this was some time ago, and it was an opportunity for me to really confront my own ableism, but also to extrapolate from what I knew about the challenges of healthcare for immigrant mothers and say, aha, I have got some transferable information about linguistic competence and how sometimes the language inside health and medical systems is not accessible to people.
Sure.
Whether because English isn't your first language or because plain language is not
It's
available.
too technical, yeah.
Yeah, the language
Yeah.
available is not plain and it's too technical. And there are also access issues related to money in the immigrant community. If you don't have health insurance, as some people do not, or in the disability community with sort of public funding models, there's always a scarcity of either providers or systems or money to get what you need. There were also issues of disparities that come through other risks. So the more I thought about it, the more I realized that my personal journey and my professional life could intersect. And I could take what I already knew about health disparities and health system barriers to good care that I'd learned with the immigrant community and begin to look at disability and developmental disability in particular. It was very meaningful to me, and I wanted to be part of the research world that was looking at that.
So now you do research in this area, which we know is much needed. So
Exactly.
talk about the types of things that you're researching.
So I'm nearing the end of my career, so I will talk about what I have done in the past. I'm really quite proud of the work that I did with a research team in Utah looking at health-related quality of life. And we know that Bob Shalak and other people in the professional world have models of what the factors are of quality of life and what the indicators of those would be. We were very well aware of that literature, but we wanted something locally, tangibly useful for people in our community, and specifically in the Parks and Rec system, because they were rolling out programs for people with developmental disabilities to access rec and health promotion programs, but we really had no idea if it was moving the needle on quality of life. And so I said, well, let's pair up and let's come up with a new quality of life measure, or we were hoping it was a retread of an existing quality of life measure that would be locally applicable. And we spent, as you can imagine, much longer on that than you would
You might think, huh?
expect. And we thought we would just take an existing measure and plug it in and we would plug and play, but it turned out to be more than that.
Yeah. And where did it end up?
Well, it ended up that we came up with our own scale, and it's now it's a dozen or so items, and we've used it. It hasn't taken off, and we put it in the public domain, much to the chagrin of the tech transfer people at the university who hoped that it would be perhaps a for-profit kind of enterprise. But we said absolutely not, it's in the public domain. So it's out there. And
All right, so how can people find it?
we have a website, it's hrqolidd.com. And all you have to do is request it, and then you can use it if you like.
Okay, and again, the tool does what again?
It measures health-related quality of life for people with intellectual and developmental disabilities.
Okay, great. That's a pretty important thing to measure. And so all of you out there, get the tool and start using it.
Feel free. Yes,
Yeah,
exactly.
yeah, that's great. I'm Dr. Craig Escudé, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support. Lauren, one of the things that I ask all of my guests is to talk about three things, 3 tips, 3 words of wisdom, 3 bits of information that you think can move the needle and in improving health and wellness for people with intellectual and developmental disabilities.
I am very happy to talk about that. As my research career is kind of wrapping up, I have really poured my heart and soul into teaching. And I teach a course called Care Work, Disability Justice and Healthcare. And it's intended for students at UCLA who are embarking on a journey as a care provider of some sort. I've had students in the class that are occupational therapy, pre-occupational therapy, pre-speech therapy, pre-med, nursing students, a variety of pre-health profession students. And we use a textbook that's written by Leah Lakshmi Piepsna Samarasinghe, or maybe I got one of her forenames out of place there. But anyway, her book is called Care Work, Dreaming Disability Justice. And I have to say, my tip number one is we all need to dream disability justice. Because if we don't have a utopian model in mind, and I know utopia is a little grandiose, but if we don't have a better way of thinking about care work and care outcomes, if we can't dream it, we can't approximate it.
I'm a firm believer that if we have our intentions set to some directions, we're going to move in that direction to some degree at least. But if we don't have, like you said, that dream in our head, we're probably not going to achieve the dream.
Right, or even come close.
Yeah.
So I like that idea of keeping a better world in mind and trying to work for that long arc of justice. And I find that very inspiring.
I like that. All right, that's number one.
Number two, because I like to work in interprofessional spaces with physicians, with all kinds of people, especially with the community of people with intellectual disabilities, there's a little Gaelic saying that's on the castle in Stirling, Scotland, that says, "Whate'er thou art, act well thy part." And that kind of resonates for me. I'm sometimes not what I wish I was, or not the be-all, end-all solution to many problems, but I do have a part to play. And whatever I am, I have to be the best I can be at what I do. So I kind of have to own my mission, own my particular skill set, and realize other people can do other things.
I love that. And the other thing about that too is that, the where'er thou are part, because where thou are changes over time. And so you might be in this role at some time, and when you're in that role, do it the best you can. And your role may change down the road, and do that the best you can.
That's right.
I like that.
I like that too. And it kind of leads to my third point, which is we're all working together in this. And the whole idea is to support decision-making and support autonomy and self-determination and living the good life. And I think ultimately, that is what the medical model is about, is living the good life.
I'm glad you came around to that, because I wanted to kind of touch on that a little bit about differentiating good health care from the medical model. Because sometimes people hear, well, we need to improve health for people with IDD, and they think, oh, that's the medical model. We don't talk about that anymore. And that is not the medical model. Providing an opportunity for every person to get good health care is the opposite of the medical model, really. It's empowering people. It's allowing people to have health equity and have their health needs addressed. And that's something we want for everybody. So that's very different than the medical model.
Exactly.
Yeah.
And the medical model is not the demon that we sometimes make it out to be. Impairment is real. And people that have impairments and wish to have those impairments reduced, lessened, obliterated, that's what we're here to do. We're here to help them harness whatever technology, surgery, medication, treatment is available to lessen the burden of impairment if that is where they wish to go.
Yeah, and you can expand that to any aspect in healthcare. We want to lessen the burden of gallbladder disease in people who are suffering from that, right? And that is, again, it's not, in my opinion, what we call the medical model of the past, where, oh, you're broken, we're going to fix you. Exactly. It's not the same thing. So health equity and good health for everybody is something that we should all strive for. And you've done a lot of work to move the needle in that direction through your career. And I am so thankful, not only for you taking the time to talk with me today, but for the incredible work that you've done to help move that needle.
Thank you so much.
Thanks for talking with me.
Thanks for inviting me.
The IDD Health Matters podcast is a production of Intellectability. Learn more about our health risk reduction tools and training for supporters of people with IDD by visiting replacingrisk.com.